All right. Thanks to everybody for joining this month's Clinical Corner with Granite Peak Healthcare Solutions. I am your host, Kaile Hilliard, licensed clinical social worker, and today we're going to talk about trauma-informed care in practice in the nursing home setting. So I want to talk a little bit about what kind of things I hope that you can get from this 30-minute session, but to be fair and honest, trauma-informed care, it takes more than 30 minutes can give you. So what I'm hoping that you'll get from this is just a brief overview and some good talking points, implementation points, but this should definitely not replace, kind of a comprehensive trauma-informed care training that staff should get. Ideally, we'll talk briefly about how it shows up in long-term care, the regulatory expectations, how to document, how to care plan. We'll touch briefly on identifying trauma triggers, signs, and patterns, talk about trauma-informed principles, and then I do at the end have a whole kind of setup for grounding and stabilization techniques that you don't have to have a specialized degree to implement. It's all stuff that we will talk briefly. I won't be able to go over them in depth, just given the time constraints, but you will have access to different kind of grounding techniques and links on this slideshow too. So with that, we'll kind of get into, I'm a regulatory nerd. That's where I come from. So we'll talk about the trauma-related regulations. And I always love, real life case scenarios. So a building got cited, the trauma tag, the F699, because they failed to provide trauma-informed care in order to eliminate or mitigate triggers that caused re-traumatization for 2 of 3 residents that were reviewed for trauma-informed care out of 30 residents. So specifically, residents that had admitted with PTSD, the facility failed to include PTSD in their comprehensive care plans, identify and control their traumatic triggers, and involve the residents with the development of their plan of care, including plans for medication adjustments. So what does this tell me? This tells me that automatically I need to be looking at diagnosis lists and seeing if somebody has PTSD. So not always will people screen positively for PTSD with a PTSD diagnosis. That does not mean that we shouldn't care plan accordingly around that, because some people may have had a diagnosis of PTSD and they have their symptoms under control. So these guys, like looking at your diagnosis list and having, sorry, there's a jet going over the top, having a PTSD diagnosis should automatically tell us that we need to have a care plan in place. So the regulation itself, the trauma-informed care regulation, says that the facility has to ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences, preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. So exactly what, these folks got cited for in the slide before. There are other associated tags. So care plans, F656, that could get cited as well if we didn't care plan around trauma. But there is another one, F742, which is like a behavioral health services tag. And this one says that based on the comprehensive assessment of a resident, facility must ensure that a resident who displays or is diagnosed with a mental disorder, psychosocial adjustment difficulty, or has a history of trauma and or PTSD receives appropriate treatment and services to correct the assessed problem and to attain their highest practical mental and psychosocial well-being. So what does that tell me? That also tells me that if somebody admits to my building with a history of PTSD, or they screen positively through our trauma screening that they have signs and symptoms of PTSD, that I then need to make sure that they are referred for appropriate mental health screening and assessment and treatment outside of my facility. So that would be your counselors, talk therapists, those kind of things that we would then refer to. That's what this tag specifically is talking about. So that's kind of like regs in a nutshell. I want to talk more about like understanding trauma. So from a trauma-informed approach and organization, really the focus and the foundation should be on safety and trust. And that would be direct care to leadership, to the front desk, to housekeeping, everybody in the organization would have a foundational understanding of the impact of trauma, potential paths for recovery, that we would be able to recognize signs and symptoms of trauma in clients, family, staff, and others involved with the system, and that we would be able to respond by fully integrating knowledge about trauma into policies, procedures, and practices. And the most important one is that we are seeking to actively resist re-traumatization. So we know what people's triggers are and that we are actively avoiding trying to re-trigger them. So the definition of trauma, an individual trauma results from an event, series of events, or set of circumstances that is experienced as physically or emotionally harmful or life-threatening. And that has lasting adverse effects on an individual's mental, physical, social, emotional, or spiritual well-being. An event becomes traumatic when it overwhelms the brain's ability to cope, process, or regain a sense of safety. Trauma disrupts the body's natural balance between protection and recovery, often leaving the nervous system in a persistent state of alert or shutdown. So, two people can experience a very similar event, and one may recover easily and the other might be profoundly affected. So, it doesn't mean that they're going to have the exact same experience, the exact same response to it. There are multiple factors that are, in play as to how people end up responding to traumatic situations. So when somebody experiences trauma, it activates the body's natural fight, flight, or freeze responses. Those are our built-in self-preservation systems. That is like the brain is sending powerful chemical or hormonal signals to help our body prepare for survival and safety. And when trauma is intense or repeated, those protective systems can become overwhelmed or suppressed, sending the brain into overload or shutdown because it doesn't know what else to do to protect the physical safety or the mental safety of this person. That person's sense of safety is disrupted. The brain begins to misread danger, triggering stress responses even when the environment is safe. So when we talk about like, hey, don't approach, so and so from behind without and tap them on the shoulder without letting them know you're there first, because their brain, if they experience trauma, have PTSD, and they are triggered by that, their body is telling them, I'm not safe. And it doesn't matter that they're in our safe nursing home. Their brain is like, oh my gosh, this scenario is not safe because this is one of my triggers. Over time, those repeated stress patterns can rewire the brain, keeping the nervous system on high alert and impact mood, behavior, memory, and physical health. Unresolved or repeated traumas also increase the risk of neurological, biological, psychological, and social difficulties. And some of those include changes in actual brain neurobiology that impact the way people remember certain events. It can impact emotional regulation, which I think anybody that's on this webinar right now would be able to kind of think about somebody that, maybe have some emotional regulation issues that might be attributed to histories of trauma. And it can also impact decision making, like what are safe, healthy decisions, what aren't. Maybe not understanding that the situation isn't actually dangerous, so I don't actually need to like try to fight somebody, but maybe it's just that, they're sitting next to me in the dining room and, it is safe. It is not somebody that's trying to take over or harm me, just in this example. Trauma can also impact social, emotional, and cognitive impairments that interfere with relationships, learning, and problem solving. We can also see an adoption of high-risk coping behaviors such as substance use, self-harm, disordered eating, or aggression. And there is a really high correlation between substance use and histories of trauma. In all studies that I've looked at and have learned about, the connection between substance abuse and trauma is high. So in your facilities, if you have people that come in with histories of substance abuse, it doesn't mean that they're always going to have a history of trauma, but it should be a flag for you guys to maybe look into that a little bit deeper. As a potential path that we need to explore and provide additional support to the patient with. Chronic physical and mental health problems, including depression, anxiety, pain syndromes, and early mortality, are associated with histories of trauma. Trauma is a health risk factor. It is not just a mental health issue. Current violence can result in, of course, direct injury, such as bruises, knife wounds, broken bones, dental problems, traumatic brain injury, which generally we're not seeing that right in our nursing homes, but people may have experienced that before they come to us. Ongoing violence can lead to cardiovascular, gastrointestinal, endocrine, and immune system problems, exhaustion, sleep disorder, psychological symptoms such as depression or substance abuse. And childhood adversity and early life trauma can impact brain structures and energy metabolism, leading to a cascade of risk factors and ultimately to a wide range of chronic health and mental health conditions. So Kaiser was kind of the landmark study that did the adverse childhood experiences study. And they're the ones who, really identified this link between adverse childhood experiences and, significant issues depending on how high the risk score was. Some of the things that we see with the ACE study outcomes is that like the higher the score that you have, then on the pyramid, the more likely that things are you're going to fall into some of those categories that are on this pyramid on the right-hand side. So some of the things that they did note, there's a link between alcoholism and alcohol abuse. Interestingly, COPD, depression, fetal death, health-related quality of life, illicit drug use, ischemic heart disease issues, liver diseases, might have seen some poor work performance, financial stress, higher risk for intimate partner violence, smoking, suicide attempts, unintended pregnancies, early initiation of smoking, early initiation of sexual activity, adolescent pregnancy, risk for sexual violence, and poor academic achievement are just some of the things. Like this is not an all-inclusive list, just wanted to have you guys have a general idea of like some of the things how adverse childhood experiences and trauma can impact people later in life. Um, so this is just kind of a quick, little visual that just kind of shows exactly everything that we just talked about. Things that we might see in our patients as nursing home patients, we might see things like night terrors and insomnia, which can lead to more fatigue and difficulty concentrating, agitation and anxiety, especially in unfamiliar places, having an extreme startle reflex that could result in rage or further withdrawing from social situations or even personal relationships. We might see anger, rage, and mood swings, or residents that are feeling numb or otherwise disconnected from those around them. We might see patients that have aches and pains that have no other explanation. We can also see things like a racing heart, high blood pressure, and they also found a link between residents or patients with diabetes might find that their blood sugar levels are more difficult to control with histories of trauma involved. Chronic health conditions related to stress are also something that we might see in our patients. We also need to talk about the ways that medical care can re-traumatize patients. The state operations manual, the regulations, does specifically talk about this piece on the left that people who are traumatized multiple times often have more serious and chronic trauma-related symptoms than those with single traumas. And according to the regulations, moving from the community into a long-term care facility for an individual with history of trauma or PTSD can be a very difficult transition and cause worsening or reemergence of symptoms. That is something that we need to be aware of as providers in the long-term care world. The structured environment of a nursing home can also trigger memories of traumatic events, and coping with those memories may be more difficult for older adults. Having a broader understanding of how trauma can impact our patients in like these specific scenarios can help us be more empathetic, and we can, get that information out to the staff so everybody can maybe have a little more patience with somebody who's struggling. Um, Ways that medical care can re-traumatize patients, we need to think about invasive procedures, potentially the removal of clothing, physical touch, personal questions that may be embarrassing or distressing. The very basic power dynamic of the relationship is something to take into consideration. So nurses, CNAs, anybody who's providing care or seen in a position of power can re-traumatize a patient who had a situation with somebody or somebody's that their power dynamics were a part of the situation leading to trauma. And something that you may not be able to control, the gender of the healthcare provider, that might be something that like triggers somebody that you wouldn't necessarily have control over outside of maybe we need to find a different person to provide like XYZ kind of care. Um, being sensitive to the fact that residents are in a vulnerable physical position in our nursing homes it's helpful in terms of like managing trauma triggers. And then in general, like there is a loss of and a lack of privacy in skilled nursing homes, especially where, pericare is concerned, needing help getting dressed. Some of those higher, need areas for ADLs definitely impact loss of and lack of privacy. And I think oftentimes we get caught up as staff as like, having to get through to the next person to make sure the next person gets their shower. So we're not always sensitive to some of these situations. Common triggers in long-term care settings can also be loud overhead paging, nighttime rounding, staff entering without knocking, better chair alarms, which hopefully people are moving away from those. Bathing in continent care shower rooms, sometimes smaller enclosed spaces can be really hard for patients who have those kind of specific triggers. Any kind of restraints or blocking movement could be a trigger. Emergency drills or alarms, like this could be a big one. Then we kind of don't take that into consideration when we're always running our fire drills and the fire alarms going off. How many times are we checking in with patients to make sure they're feeling okay? Then, folks aren't having, traumatic, responses to that. Also, staff raising their voice or moving quickly can be a trauma trigger as well. Bright lights being suddenly turned on, physical touch without warning, medication administration, especially injections, could be crushed medications. Like there's people who have medical trauma as well, even before coming to us, and being aware of that can be very helpful. Other residents having behaviors that are loud or maybe uncontrolled or could be scary for residents who have experienced violence before, that could also be a concern. So keeping that all in mind will be helpful. Trauma-informed care screening and documentation is the next little section we're going to cover briefly. So a foundation of trauma-informed care is moving from what's wrong with you to what happened to you. So to provide a truly trauma-informed care, staff have to shift that perspective from viewing behavior as just being non-compliant to understanding it as a communication of unmet needs or past harm. So when caring for a resident with a history of trauma, staff should consider underlying factors that may be driving the behavior. It could be fear, loss of control, there could be some sensory triggers. We also need to consider the extent and the nature of the trauma experiences, both past and current. That doesn't necessarily mean that it's going to be a part of everyday conversation. It's just how when we take into consideration, like somebody might have been into a really horrific car accident 25 years ago. And so that would be different trauma than somebody who experienced domestic violence over a multitude of years. So those trauma triggers may be very different. Like it might be a loud noise for, the person who experienced the car crash, and for the person with a domestic violence, it might be, being in closed doors, having clothing taken off, and how that's done. So we would need to be just sensitive and have that in consideration. You also want to take into consideration ongoing trauma or potential re-traumatization within the facility environment, and how that might be impacting the patient. You also want to take into consideration cognitive level and capacity that for folks to be able to process and communicate distress. And then care plan integration, ensuring triggers, coping strategies, trauma history are documented and shared with the IDT team so that the appropriate amount of information can be shared in terms of what are the triggers. And when we talk about care planning, you don't always have to go into great detail on what their trauma was per se. It's more important that we know what their triggers are. So it can be a simple one-liner, history of trauma related to domestic violence. Their triggers are X, Y, and Z. And then we have interventions that address that. Trauma-informed care is not about fixing behavior, but about fostering safety, control, and connection. So 4 C's for caring for patients who have experienced lifetime trauma. First thing is to be calm. Pay attention to how you as a staff are feeling. Breathe and calm yourself to help model and promote calmness for your patient. Contain. Ask the level of detail of the trauma history that will allow the patient to maintain emotional and physical safety. Respect the time frame for your interaction and allows for you to offer the patient further treatment. So I always tell people, like, We don't necessarily want to, there's some people who will trauma dump and they will tell you everything about the trauma, and that is actually can be more harmful. Their brains, they've done studies on this where under MRIs, people are actually reliving sometimes trauma when they're trauma dumping, having those conversations. And staff need to know that they can establish like, hey, this sounds like this is a bigger conversation for maybe social services, or let's refer you back to your therapist. It is harmful if we ask about trauma and then we don't have the time to appropriately, like, manage the conversation. If we're just cutting them off, abruptly and moving on to the next thing. So I think there's words that we can use and we can give staff to be able to help contain, the situation so we're not causing further harm. And also, ensuring that staff aren't asking for details on their trauma. Like that should be between a qualified mental health professional and that patient, not necessarily the CNA or the nurse or the social worker that, if it's a trauma situation, that it needs to be referred to the appropriate person. We also need to emphasize good care and compassion. And then coping mechanisms, emphasizing skills to build on strength, resiliency, and hope for our patients. So it's helpful to know, like, not only what are your triggers, but what are your coping mechanisms and how do we, help move you forward. So we should have like really good coordination with mental health providers as well, so that we can build up the care plans with appropriate interventions with our residents. Trauma assessment and screening. So in the nursing home setting, we do screening. True trauma assessments really need to be, referred to qualified mental health professionals. So our role is to screen and see if people are having signs and symptoms of PTSD, or if they have a history of trauma that they want to get some therapy for. So we would do screening in the long-term care setting. Assessments, truly, like that word assessment, should go to a qualified mental health professional. Screening, our responsibility, should be conducted routinely, part of our admission, an ongoing assessment process. So I am personally, and like at this point, not a fan of quarterly screening, just because I don't want to re-traumatize a patient. That doesn't necessarily mean that if your company has that as your policy or your procedure, it's wrong. I just think admission, and then if there is a significant event, like if somebody fell out of a Hoyer, fractured, had a new situation come up, or was involved in a resident to resident, that might be a time where I would do a new screen. So, and that should be like we find what's going on with them and if they need some additional support, and then we help, facilitate that referral to a qualified mental health professional. Trauma symptoms can be misdiagnosed and overlooked, especially when combined with existing mental health or cognitive conditions. And during screening, staff should ask about known triggers and effective coping mechanisms to guide individualized care. So if I'm doing the trauma screen, and different facilities have different screens that they like, part of that conversation should be, hey, do you know what your triggers are so that I can educate my staff? And then do you have any, coping mechanisms, things that help you, get through this, get through your day? And that is information that will help build that care plan right away for you. Staff should also be trained on how to redirect or de-escalate residents who become distressed during screening or discussion of sensitive experiences. So this is one of many screens out there. It's the abbreviated PCLC. It is one that I think works really well in the nursing home environment. That said, there are different ones out there and different companies use different ones, and there's nothing wrong with those either. I just wanted to have an example so you could kind of see what a screen might look like. So then if somebody scored high on this, then we would refer them, or we'd ask, do you want to see somebody, to address the signs and symptoms of PTSD from your screen. In progress notes, how do we document trauma-informed care? So you document the trigger, what happened, what led up to it, document the resident's response, document the intervention that was used, document whether it helped or not. And then you'd also want to know any pattern or escalating theme to trauma-related behaviors, issues that have come up. And then update care plans, ideally the same day if possible, or at least the very next day with your next morning meeting when a new trigger is identified, and ensure progress notes reflect trauma-informed language. So anytime we do an care plan update, and if a new trigger is identified or a new intervention is identified, the regulations are pretty clear in that they want to make sure that direct care staff are aware of them. So I would make it a habit of making sure that information gets disseminated out to the direct care providers, the CNAs, the nurses. I look through a lot of Cardexes when I'm doing different reviews, and I'm not always seeing, non-pharm approaches for trauma, for behavior included in the Cardexes. And so CNAs are not generally getting into care plans to be able to see what we're putting in there. So we have to have some method of communication on what, trauma triggers are, what trauma, interventions are. So I have an example for when we're talking about care planning for a trauma. So the problem, like this one, Irene is not a real human. Irene carries a diagnosis of PTSD related to a history of domestic violence. She becomes easily startled and experiences distress when the room is dark. That is an example of somebody with a known issue with PTSD. So there, I also have an example of when trauma is suspected but not confirmed, because that does exist. Residents suspected to have a history of trauma based on reported statements such as, family reports history of trauma with domestic violence or whatever, based on information shared by family, although details remain unclear and unverified. So you can still have a trauma care plan even if you're not 100% sure. Some examples of goals: reduce startle responses during identified triggers over the next 30 days, have the resident verbalize one effective coping strategy during the periods of increased anxiety, participation in supportive trauma-informed interventions at least 3 times weekly. And then here's some just examples of interventions. Identify coping mechanisms or triggers, provide trauma-informed care approaches, modify the environment as needed, monitor for signs and distress, communicate triggers and interventions to the care team via the care plan, Cardex, and report. So just, simple example. You guys might have better ones, and obviously you want to individualize it. So I don't want you to just copy and paste this and like, yay, we have a care plan for trauma. Like, it really should be built on what information you're getting from the residents. We also want to talk briefly about non-trauma responses. So trauma generally has a pattern reaction to triggers that are often sudden and intense. Dementia usually have a progressive cognitive decline with inconsistent triggers. Trauma behaviors generally improve with grounding, therapy interventions, and generally dementia does not, because it's a progressive disease. Some other things that are non-trauma responses: conditions like anxiety, OCD can exist independently of a history of trauma. So you can have people that are having anxiety that they don't have a history of trauma to like associate that with. So that might be that care plan is going to look different. Um, just attachment styles and coping with stress, engaging in healthy coping mechanisms like physical activity, creative expression, such as art, is a positive non-trauma response to stress. That's really what we're aiming for people to get to is, positive mechanisms for managing PTSD, their triggers, and that kind of stuff. So trauma-informed care and practice. Trauma-informed care, what does it look like? Language and communication, first of all. Our helpers use non-judgmental, empathetic language, avoid making assumptions about the individual's past, providing choices. That's always a helpful thing instead of us just dictating and telling people how to do things or what to do. Offering choices to patients can be empowering, allowing a patient to choose their meal preferences, time of their therapy. That can give them a sense of control that they might be missing. Sensory-friendly environments is another way to provide trauma-informed care. So providing calming sensory rooms, ensuring lighting and noise levels are adjustable. Active listening, helpers actively listening to individuals without interrupting or rushing through appointments or care can validate feelings and experiences too. Training in self-care. Healthcare staff are trained in trauma-informed care principles, encouraged to practice self-care in order to prevent burnout. And then de-escalation techniques. So in situations where patients may become agitated or distressed, that trauma-informed care involves de-escalation techniques that prioritize safety and minimize the re-traumatization. So helping means reducing the sense of threat, create a soothing environment, train all your staff, take the time to get to know the patient, adopt collaborative person-centered approaches, offer choices, be mindful of what we're bringing to the table when we're providing care, be mindful of the difference between expecting compliance versus cooperation. Those are all help to reduce the sense of threat that can impact a person's, trauma experience. So some grounding and stabilization techniques that you should just kind of have in your back pocket is if somebody is, kind of in the middle of being ungrounded related to trauma, helping them take slow, intentional breaths is number one, just to calm the brain, and get it out of that cycle of trauma. And then this one is one of my favorites, is offering a cool drink of water or a few ice chips if they're appropriate to be able to swallow that, just because the temperature change in itself can help bring back awareness to the present moment. So if they're, like I said, in a situation where they're overwhelmed with trauma. Um, Listening to like sensory things, feeling sensory things like different textures, whatever the sounds are, doing some things to get their body moving. I personally love to get people like out of the environment that they're currently in. Maybe they need to take a walk or, a roll down the hallway or quick outside, get a cool nice breath of fresh air. um, those are all things that are quick grounding stabilization techniques that people can use. I'm going to quickly roll through these next ones, but five senses exercise is something that you can have somebody do. Mindful seeing. This quick 3-minute video on tapping is helpful. I encourage you guys to kind of go through it. And then Teepa Snow is amazing. She does a really great job on de-escalation. So this video, if you click on the link, it actually works to take you to that YouTube video for that. Um, and there's body scans that are helpful. And I've just linked body scan scripts. Then these are things that I would practice with residents too, if it's appropriate for them. Wheelchair yoga is, this lady does a great job. It's a quick little 11-minute thing. But again, these aren't things that you can just throw at people all of a sudden. These are things that you would want to practice with them. And of course, if it's helpful and it's not contraindicated. And then got some resources for you. So that is trauma-informed care in 31 minutes. So I'm going to open it up for any questions that anybody might have right now. And I'm going to check the chat too. So, all right. Anybody got anything? And yes, Melissa, you can have. I will attach the YouTube video to this and also the slides to the calendar invite. So you guys will be able to get this and check back on the calendar invite. Anybody else? All right. Well, thanks for joining. Always a pleasure. You guys have a great weekend, and we'll talk to you sooner than later. We'll be doing a clinical corner. It may be paused for December just because of the holidays, but you guys will certainly send out, a message on when our next one is and what the topic is. And if there is a specific topic that you guys would love to see, please feel free to email us or send us a message. All right. Thanks so much.